All right.
Great. Thanks, Brian. Before I get started, can everybody see the slides that I have up? Great. Okay, well, thank you everybody for joining. I'm very happy today to talk to you a little bit about our Contingent AI webinar. If you have any questions at all, please feel free either to use the chat feature through Zoom or to, just shout it out and I'll try to answer as best I can. So let's get started. So I always like to start with this idea of where AI is currently being applied in large industries. This is an example. This was a survey from the pharmaceutical industry that had looked at, where they were kind of seeing the most application of AI internally. And it was mostly in areas that you might expect. So things like, target identification, safety, very verticalized, very specific projects where it's quite easy to demonstrate an ROI and convince executives that it's worthwhile to begin, kicking the tires on AI. The point of this entire conversation today is to convince you that this is basically the worst possible way to employ machine learning in a large institution. And I'll get to exactly why we think that is. But I'm going to start with an example. So one of the first projects we worked at with BioSymetrics was to build a diagnostic model for autism. So we had about 1,000 MRIs and fMRIs for control patients and autistic patients. What we wanted to do was build a framework that would allow us to diagnose, autism spectrum disorder. So this is an area where there's a bit of a subjective diagnosis, and so there's clearly a value in terms of building a quantitative metric that can indicate disease or non-disease. So we spent about 3 or 4 months building out a framework that could allow us to process these images and extract these network diagrams, which you're seeing on this slide. So these kind of hairballs. In these diagrams, every node or every dot is a different region of the brain, and every link between them is whether or not there's coordinated firing during an fMRI of those two regions of the brain. And these are average representations. So these are averages of the control patients and then of the autistic patients. And so clearly there's a distinction. We were seeing this more coordinated firing among control patients when compared to autistic patients. And so this to us was fantastic. So this is clearly the basis for a discriminative model. The issue was when we started to take this same model that we had trained on these patients, we saw that it really fell apart. It really lost efficacy when we started to look at patients who had their MRIs done on different devices. And so we started to go back to our process. And so we looked at what we had done in terms of every decision we'd made, from going from the raw data, the DICOM images, to building our machine learning model. And so we'd made some decisions in terms of how we were thresholding the pixels, how we were registering the brain images, how we were subtracting the skulls from those images, how we were doing volumetric analysis and image smoothing. And basically at each of those steps, what we'd done was either rely on the input of someone from the field, or went through the literature and selected options that way, or selected the default values for the software. I should also mention that these steps where it's more linear, where there's just kind of a straight path, was by far the most time-consuming part. So this took probably like I said, 3 or 4 months. When we had the features extracted, when we finally had some numbers that we had taken from these MRIs and fMRIs, then we got to the machine learning. And so this is where we had a lot more comfort and a lot more familiarity. And so we knew enough to permute through a few different types of algorithms, permute each with a few different types of options. And we could play with that space a little bit and come up with what we thought was the best model for the data that we had. When we started to look a little bit deeper into the literature, we saw that the decisions that people were making in the pre-processing would lead to either more or less connected brain networks. And so there was this huge impact in terms of the pre-processing decisions people were making on the outcomes they were seeing, both in terms of brain connectivity and diagnostic models and you name it. And so we thought, what if we had a framework where we didn't make any decisions, where in the same way that we tune a neural network or we tune some other machine learning algorithm, we could basically tune every decision that we made in the pre-processing. And so that was the basis of Contingent AI. What we're basically doing is extending the idea of parameter optimization all the way through to the pre-processing. So anytime there's a decision point that has to be made, we basically will permute multiple options and we'll look at the effect on the downstream model. So taking a step back to the data that we actually generated for this process. So what you're seeing here on the left is a heat map. And on the x-axis, each of these are a specific region of the brain. On the y-axis, each of these are a different run or a different combination of pre-processing parameters. And what you can see within every cell is the amount of pixels of each of these regions of the brain that were described as being gray matter by this framework. And so there's a huge disparity. So you can see just by modifying a few of our options for the pre-processing, we see these wild swings in terms of what we're classifying as being, gray matter versus white matter or CSF. And so the pre-processing has a huge impact in terms of what we're identifying, concretely within the brain. How does that translate into our model performance? Well, these graphs on the right, here the axes are flipped a little bit. So if we look at this top graph, this performance graph, where we've got on the x-axis now is our iteration number. And so this is, again, our combination of pre-processing parameters. And on the y-axis is our performance. And we can see that there's these huge variations. So we see this kind of periodic changes in performance. And these reflect the impact of the pre-processing decisions we made. So not only are we kind of influencing the amount of gray matter that we see for each of these brain regions, we're literally influencing the performance of our model, more so than our selection of algorithm or our selection of parameters for that algorithm. So the pre-processing really carries even more weight than any of the decisions we made for the actual machine learning. This graph just underneath it is related to bias. And so what we're illustrating here is basically how similar different patients are, based on different categorizations. So for example, the blue and green represent patients that are similar in terms of age and gender, and the orange represents patients who had their MRIs taken at the same site. And the higher you are in this graph, so this bias metric indicates basically how much more similar you are than random. So you want to see these age and gender specific relationships, or these age and gender specific biases as being, you expect there to be a bit of indication there or a bit of volume there. But site ID really dwarfs all of these. So there was this huge impact in terms of a site-specific effect that was just being picked up by our machine learning algorithms. And so this is what we thought was a well-performing model, actually was not. We were just recapitulating biases that were introduced by site effects. And so why is this consequential? When we think about what's really limited the effect or the success of machine learning, it's been this recapitulation problem. The industry runs into this time and time again, where we build really good models. Even on cross-validation, they may look good, but then they just don't hold water when you apply them to different populations. The only way we've seen really to circumvent that is to include more diverse data. So we've seen through having built diagnostic models for a range of disorders, if you're able to build a model that's based on features from, let's say, the MRI plus metabolomics plus genomics, you'll always build a better model than any model that's built on those individual data types alone. You can intend to increase not only the accuracy of that model, but decrease the biases of that model. And the reason that we think that that's the case is because each of those individual data types are subject to their own bias. And so when you're able to incorporate them, you basically have a data set that is less kind of influenced by each of those individual biases. So when we think about this initial model that I presented, where we have these kind of very verticalized, very localized applications of machine learning when it comes to industry applications, the danger there is that we continue to run into the same obstacle. So why is it that we haven't been able to move beyond that? And why is it that we haven't been able to create machine learning models that are drawn from a wider range of potential data sources? So the first is biological data are notoriously difficult to work with in that they're very heterogeneous. So even among the same data type, there are, like I showed you with the MRI example, There are lots of different types of machinery. There's surveyor bias. There's a lot to be accounted for there. And that's within one type of data. So it requires a lot of expertise to know how to process MRIs. And that's entirely distinct from the expertise it takes to know how to process ECGs or chemical structures or tabular data, EMR data. And that is entirely distinct from the expertise it's required to run machine learning. And so what tends to happen is that groups are set up with one person being the expert in each of these individual areas, and they'll each make their own decision and not really think about how each of those decisions is impacting the model as a whole. And so between this heterogeneity and this lack of standards or this high bar in terms of expertise that's required, you tend to get the same problem over and over and over again. So what we proposed ultimately was a framework that could process each of these individual data types in concert and do what I had showed you previously, in that no individual decision is made without permuting several options. The difficulty there is then there's a lack of scalability. So using this type of framework requires a lot of permutation. And if you don't have a software framework that can leverage cloud computing, leverage GPU computing, you're going to have a lot of difficulty in terms of building out these types of models. So this is exactly what we try to address. And this is exactly the nature of a contingent AI. It doesn't work unless you're able to process multiple data types simultaneously. And it doesn't work unless you're able to permute options for these different types of data, or for these different options from the pre-processing. So our Augusta framework has specialized aspects of the code that deal with medical images, with streaming data, with genomic data, with clinical data, with chemical compounds. But wrapped around all of this is a permutation layer, wherein you can permute options, whether it's for subtracting the skull out of a medical image, or identifying different fingerprint libraries to work with in generating activity prediction models, to how you imputed your missing values for your clinical data. Effectively, any decision that's made, we can permute over several options, and we can look at the effect of that in terms of the performance of the downstream model. So that's the nature of contingent AI, allowing you to permute options and optimize options at every stage of the analytic pipeline, whether that's the pre-processing, data integration, feature selection, or machine learning. The entire nature of this framework is that you build models that you recognize will have a shorter half-life. Like I was saying in the introduction, it's all too common to apply machine learning on one particular data type, and it's all too common to design a model and then expect that model to be static. What we see in practice is that there's a requirement for models to evolve and to adapt based on changing aspects of the data, based on changing patient populations, based on alterations in your population demographics. And so the way that we always approach AI is to allow the framework to identify the optimal set of parameters through a combination of pre-processing, feature selection, and machine learning. And as that data changes, as your patient population evolves, as your experimental data changes, you want to be able to re-optimize that model. You want to be able to rerun that model and have that be optimal for your new set of data, or for your most up-to-date set of data. And so what we provide is a framework that allows you to not only build these optimized models, but continually refine them. In terms of use cases, so we've certainly applied contingent AI across a range of diagnostic cases. Here you're seeing examples for identification of prostate cancer from, in this case, multi-parametric MRIs, and also for identification of atrial fibrillation, traces. What's unique is not only that we can permute multiple options for the pre-processing for each of these individual data types, but how seamlessly we can then incorporate other types of data and have, for example, genetic context or medical history context be incorporated into our diagnosis of prostate cancer that's built primarily using, in this case, multi-parametric MRI. One other area that we've put a lot of work into is in activity prediction for small molecules. and generally in terms of early stage R&D analysis in the drug discovery industry. And so what we've done here is we began with a framework that was actually designed to work with experimental data. So this little guy that you're seeing here in this black and white image, that's a zebrafish embryo. And the way that is that these are kind of a popular experimental platform for drug discovery in that they're a transparent model organism. You can put them under a regular microscope, add in the drug, and you can look 24 hours later. You can say, okay, is the heart developing normally? Is the brain developing normally? Are there alterations in terms of pigmentation or body axis or structure? And then you can associate these different endpoints with chemical structures. And so we began by building models that could predict these type of effects based solely on chemical structure. And then we started to layer in other types of experimental data. So we worked with the top 5 global pharma to layer in transcriptional information, proteomic information, and genomic information for these same small molecules, and begin to not only predict the effect of these small molecules, but also the mechanism. Now with current work with partners at Harvard Medical School, what we're aiming to do is build an entirely autonomous drug screening platform, where we're taking our initial predictions, we're tying that with high throughput experimental validation, and we're using that to refine our initial prediction framework. And so ContingentAI is used to build those initial models. And then the refinement is used in a continual feedback cycle where we're looking to always optimize and re-optimize those initial prediction parameters. Okay, so that's the extent of what I was hoping to present today. I'm happy to take any questions if you have them. And of course, if there's anything you'd like to send to me, you can send it to my email address and I'll respond via email as well. Thank you very much. I'm very glad you were able to, and I hope, I hope it was informative.
Hey, Gabe, this is Jeff.
Hi, Jeff.
Hey, a question I have is very interesting what you described, but one thing I wanted to mention, which I think I've told you before, is there's the top genomics guy at Mount Sinai, Eric Schott, and his phrase is genomics is a necessary but not sufficient condition, which is exactly what you're showing in each one of these silos you're integrating.
Yeah.
So what I'm wondering is, when you tweak the different silos and pre-process the data, do you ever find situations where you want to completely eliminate one silo, where the biometric results or the genomics just don't fit with the other 5 or however many there are?
Oh, it's a great question. So certainly there are, I would say, cases where one type of data might be less informative than others. In work that we've done, practically speaking, I can tell you that models that we've built have tended to draw upon features from these different data sets fairly equally. We don't tend to put our thumb on the scale, so we don't tend to pre-bias it by saying that for a given diagnostic problem, we want to rely more on the genomic data than, let's say, the metabolomic data or the imaging data. Although that certainly is possible if someone has some reason to suspect that there are quality differences or some other differences that would make them want to emphasize one type of data over another, they certainly could do that. But the entire nature of our framework is to allow that data to be combined in different ways and to ultimately have the performance of the model be the arbiter in terms of what was the correct combination of features. And so to answer your question, yeah, we certainly do appreciate that. In some cases, some data may be more valuable to a diagnostic model than another one may, but we feel our framework is robust enough to identify that.
Well, the reason I brought it up is I'm working with a diagnostics company that's working on liquid biopsy.
Okay.
And so they're working in liver cancer, and so they're able to detect liver cancer recurrence much more quickly than the typical diagnostic, which is an MRI. So there may be situations where if you knew how reliable a liquid biopsy was, which is far from a gold standard right now, and an MRI is a fairly expensive procedure, that there may be ways in which you could look at pre-processing without the MRI and look at the results and then decide whether or not to add an MRI to the data set.
You certainly could. And you could, in fact, do even more than that, where you could put these modalities against each other and you could compete basically the performance of these different modalities. That certainly is something
Right.
that's certainly achievable through our framework as well. Yep.
All right. Thank you.
Thanks, Jeff. Appreciate it. Okay. If there are any more questions, please feel free to yell them out. If not, send me an email. I'm more than happy to respond. Very glad that you're all able to join today.
Hey, this is Arshad. Good.
Hey, Arshad, how you doing?
Hi, good. Hey, listen, I have a question for you.
Yeah.
I don't know too much about the MRI space, but I'm thinking more, that chart that you had up earlier about the variability that the pre-processing technique causes at different stages.
Yeah.
Right. No, yeah, the slide before that. So there's 6 or 7 different stages of pre-processing, and the results could completely be different, right?
Right.
Depending upon what process you how big of an issue is this for, say, I don't know what other data sets you have similar charts on, but I want to understand what is the extent of this problem in genome or sequencing or flow cytometry or immunohistochemistry or any of those analytical data. Because what I've heard in the past is the variability is caused not in what you're talking about, it's more on how you process the samples in a lab, right? How do you prepare the sample? How do you clean? How do you, whether you use dilution ranges, that could cause variability. Temperature of the sample. But you're talking about something different. When you say pre-processing, you're not talking about that type of pre-processing. You're talking about something to do with the data itself.
Yeah. So that's
what is the equivalent in the in vitro diagnostic space or in the in vitro space?
Yeah, absolutely. So I can tell you, I don't have the charts handy to support it, but I can tell you from having worked in that area, at least anecdotally, there is a huge difference in terms of, effectively every aspect of alignment that you're doing for genomic data. And that applies whether it's, genomic data or transcriptional data. There are decisions you make in terms of how you're normalizing transcript counts, how you're, the statistical model you're using to identify, alterations as opposed to variants that should be discarded or reads that should be discarded. And you can just, literature, it's very well established that your choice of statistical model has a huge impact in terms of what reads are kept versus which are discarded. So to think that that doesn't have an impact in terms of whatever downstream analytic model you're using is, to me, I think, folly. So the way that I would approach that would be, again, not to assume that any one model or any one processing step for in vitro data would be beneficial for all problems. And so I would always go the route of trying to permute as many different options as you could and identifying that for different applications, different sets of parameters are going to be optimal. Now, that didn't quite answer your question about data handling, which is an entirely separate but equally important issue. So, for example, if you're working in flow cytometry or really any aspect of experimentation, there's a major manual element. There's always surveyor bias, there's experiment bias, there's temperature bias. The more of that you can identify, the better you can account for it. But ultimately, you're never going to get rid of it. The machine learning is far too sensitive, or AI is far too sensitive to all of these minute grooves that are worn into the data, that no matter how well you are dealing with confounding variables, there is always going to be a trace of it. My recommendation is maybe not appropriate for all scenarios, but I would say the more you're able to rely on multiple data sources, the more you can effectively sidestep that bias. It's really the only way, at least in my experience, to deal with it entirely.
Okay, thanks.
No problem. Were there any other questions I could answer? Okay, so I'd just like to end by thanking everybody again. And if you have any further questions, please don't hesitate to email me. I'll talk to you guys soon.
Thanks, Gabe.